Well, hi everyone. Thank you so much for joining our talk tonight on managing UTIs in the pharmacy setting. We're so glad that you've all been able to, take some time during your evening and listen to this presentation. So I'll introduce myself. I'm sure you've seen my name on the many emails you've received over the past week. My name is Jyoti. I work with UTIVA Health. And then my colleague Faraz Nomani, he's here as well. He's one of the co-founders of UTIVA. And then our speakers for tonight are Sean Simpson, he's a pharmacist, and Dr. Sulaiman Firmly, he's a family medicine doctor. So before I formally introduce Sean and Dr. Firmly, I'm just gonna do a quick run through of our agenda for tonight. So Sean's gonna do his presentation on managing UTIs in the pharmacy setting, and then Dr. Firmly will join in afterwards and cover his just some tips and tricks on managing UTIs from a medical doctor's perspective. After that, we are going to move into the Q&A. So for that, just be sure to add any of your questions throughout the presentation into the chat. We'll be adding them to a list and we'll do our best to get through all of them. We usually have quite a few, so just make sure you start adding them as we go and we'll add them to the list. And then after that, we are going to do a raffle. The raffle, just make sure that you're there to claim your prize. So if we draw your name, you just need to make sure you're there. So just hang on for a little bit after that. And then finally, we are going to do a quick introduction into the UTIVA portfolio at the end, 5 to 10 minutes. So if you want to hang around for that, that would be great. Okay, so I think that's it for our housekeeping. And I'll go ahead and introduce Sean. So Sean Simpson is a pharmacist and an owner of Simpson pharmacies in Niagara-on-the-Lake. Sean is a third-generation pharmacist and graduated from the Leslie Dan Faculty of Pharmacy at the University of Toronto in 2006, and also has an honors degree in chemistry and biochemistry from Western University. In 2015, Sean completed a fellowship in nutritional and metabolic medicine with the Metabolic Medicine Institute affiliated with University of South Florida School of Medicine. Sean was also the chair of the Ontario Pharmacists Association from 2015 to 2017, and was also a director with the Canadian Pharmacists Association from 2018 to 2020. He is an active member of the board of the United Way of Niagara, also having served as a campaign chair in helping with the successful amalgamation of 3 United Ways in Niagara. Sean lives in Niagara-on-the-Lake with his wife Stephanie and children Natalie and Luke. Thank you, Sean, so much for joining our talk tonight.
Thanks, Jyoti, for the warm introduction. I really appreciate it. I'm happy to be here and happy to be joined by so many of you online. So thanks for joining in. I'm excited to work with UTIVA on this project, as well as just going over some new exciting changes for pharmacists in Ontario, and I'll certainly be sharing the Ontario perspective more than anything. Even with all the fancy introduction, I don't claim to be the world's foremost expert on UTI management, nor do I think I've done many more minor ailments consultations than a number of you that are probably joining here today. But hopefully collectively we can walk through the process, at least the Ontario perspective. We may be able to learn from others across the country if they've joined in, and look at some options that we have, the new process that we have here in Ontario, and some considerations in treating UTIs. So thanks again for joining. I'm trying to advance my slides here. So we've quickly gone through here, as Jyoti has said. So we'll just quickly kind of get through this. I'm going to try and keep my portion to about 20 minutes, leaving time for Dr. Firmly to give the physician's perspective. But I'll walk through basically just the whole kind of concept of the minor ailments, the UTI treatment algorithm, particularly, again, referencing the Ontario perspective and the Ontario College of Pharmacists algorithm guidance that we have, and work through some of the tools that we have at our disposal and we will touch on the Utiva products that are available for prevention and synergistic treatment as well. So, but just looking at minor ailments across Canada, I don't have the stats on how many of you are joining from each province, but the great news is especially for UTI, this is a scope of practice that almost all of us will be able to implement this year. BC, I believe, is the last province to join on, and that is coming at some point this year. We've heard different perspectives as to whether that's going to be earlier in the year in the spring, or I've heard most recently that it's been pushed back to the fall. And you can see across the other provinces that there are, a range of fees that are being paid from $18 to $25 per assessment. There are a couple provinces like Manitoba, New Brunswick, and PEI where the minor ailment funding is more or less limited to UTIs. I think there's a couple of conditions that they may be treated, whereas in Ontario, of course, we have 13 common conditions, and other provinces it differs. I believe Newfoundland, there is no funding, but they have quite a wide list of conditions. So I always keep myself up to date. If you see the credit on the bottom of the slide there, the Canadian Foundation of Pharmacy has a great website, and they keep track of all the scopes of practices across the country, and you can see what other provinces are doing and what they're funded. And I don't think much has changed. I think we're all still shooting to be like our friends in Alberta, where independent prescribing is available for a number of Schedule I medications. So that sort of sets the table here. So again, just going through the Ontario perspective and the process for minor ailments. This is not specific to UTI at this point, but just trying to identify patients that are eligible for different consultations. So quite often we'll see the patient will have heard that the services are available, and they'll present at the pharmacy and enter into a discussion or request a consultation. As time goes on, I think you'll see referrals from other healthcare providers as they get more comfortable understanding what the scopes of practice are. And of course, I think through our normal course of educating and consulting with patients, we'll be identifying patients during a discussion that may benefit from a minor ailments consultation. So nothing new here. Again, for most, I think you'll know, like a private consultation room is strongly recommended. Explaining to the patient that the consultation is going to take 15 to 20 minutes. So we can allow for information gathering on health status, medication, symptoms, etc. Based on that consultation, of course, we'll be able to provide them with guidance on how to treat the minor ailment, and certainly write a prescription if appropriate through the course. And we'll walk through the algorithm in the case of UTI here, just to see how that process goes. In addition to providing the prescription or any recommendation, we're going to be expected to monitor the patient. So there's, generally speaking, a follow-up assessment that will need to have happen after a minor ailment. So sometime, usually within a week, is appropriate time to follow up. And also notifying the patient's primary care provider with the record of the assessment and the treatment plan. So again, this is largely Ontario-centric, what I'm providing. I do believe there might be some differences across each province, but I ask for your understanding and knowing that I'm no expert outside of this province, and we're still just getting going with what we know about this exciting new scope of practice. One other element of this, of course, is getting documenting informed consent. So, of course, this can be explicit and written, or very often it can be considered to be implied during the course of engaging with a patient. As far as conducting the assessments, ensuring that it's done to a certain level of detail, there are a number of tools and forms you can use. Always a good idea to use an intake form for new patients to make sure you're gathering all their pertinent information, their contact information, their medications, conditions, and allergies. In addition, going through obviously their presenting symptoms, figuring out how long they've been presenting for, whether these are new or old, and also asking about whether they've already tried treatment for these conditions. Because I can tell you in the context of the number that I've provided over the last month or so, quite often we've seen patients that have tried a couple things already. As far as looking at the documentation, again, I've used in Ontario, there's a new platform called MapFlow, which I quite like. I've also looked at the Vigilance platform that's integrated with MedMe. There's a number of other tools that are out there. So still trying to find our way as far as what we like best. And I certainly encourage everybody to play around and find them. I'm told as well that the one CE accredited CE provider, I think Pharmachief, has a very good library of documentation forms as well that you may want to consider using. Always for every assessment too, we're going to be looking for red flags, especially to identify those that are beyond the scope of treatment within the pharmacy and may need to refer to a physician. And then another final piece, and again, Ontario specific, but I think across the country, there may be access to clinical viewers. So we use Clinical Connect in our practice, and it's something that we've been set up with, and very helpful when it comes to looking at medications or recent hospital stays and accessing lab values so we can understand prior treatment for our patients. Of course, at the end of the consultation, you're going to be looking at making a recommendation. The good news with all of the conditions is that we have some very robust treatment algorithms that help to guide recommendations or determine whether referral is required. I think there's one tidbit that's often overlooked is really involving the patient in the decision-making process. So when you get to that final decision-making step, you may want to review some of the options with them and find out what may work better for them. There could be cost considerations. There could be, timing, dosing, administration considerations that are all relevant to identifying what's the most appropriate treatment for that specific patient. Once we've decided on that, we write the prescription and document in whatever tool you're using. And of course, as we've already well known, we've been able to recommend Schedule 2 or 3 products since the beginning of time, I guess, would be one way of explaining it. But now we can include a prescribing of a Schedule 1 product. And of course, the one caveat that although I think in the vast majority of cases, patients would be more than happy to fill the prescription at your pharmacy, they're not required to do so. And it's important to let them know that if they wanted to take it elsewhere, they could. And that may also be useful in the context of, at least in Ontario, where we're able to provide virtual or care over the phone, and maybe your patient is out of town. You can still look after them, but maybe get that prescription to them wherever they may be. Looking at monitoring parameters as well. So establishing a therapeutic goal or outcome. What do we want to see have happen? How are we going to monitor for it? And when it'll be reached. Looking at who's going to monitor the progress. So certainly we put a lot of impetus on the patient to be able to monitor their own improvement, and establishing when we will set up a follow-up call to figure out if that treatment is indeed working. We always want to establish with the patient that, if things get worse, what they should do right away. If things are taking a good course, then nothing needs to really happen. But if things get worse, then we want to make sure that they know that they should seek other care right away. And another reminder here that we are required, at least in Ontario, to notify the primary care provider. So whether that be, currently we're still using fax, although Doug Ford says that we're going to be getting rid of the fax sometime soon. The requirement in Ontario is to send off the patient information along with the pharmacist and the prescription, as well as the follow-up plan to the primary care provider. And from my experience to date, some of the tools are very good at assimilating that information and making it very easy, so it's not a cumbersome process. And of course, document. So we are required to make sure that we include all of this information and keep it on file. And generally speaking, these tools are very good at keeping and maintaining that information that you've gathered And you can also scan it into your pharmacy software solution as well. So just wanted to go through here. So this is the beginning of our UTI algorithm that has been published by the Ontario College of Pharmacists. So if you see just, initially what we're doing is we're going to assess the patient. And a UTI patient, we're typically going to be looking at a presentation. So first and foremost, does it hurt when they pee, or are they going frequently? Acute dysuria is sort of the one thing we're looking for. Or on the other hand, 2 or more of the following, which are a new urgency or frequency, pain, significant pain, or blood in the urine. So looking at those would be things that we would want to know if those are present. And if they do meet that criteria, then we'll carry on. If those criteria are not met, then we typically wouldn't prescribe antibiotics. So some of these other symptoms we would want to, if they have the other symptoms that are presented here, we're going to pass them along to a physician or nurse practitioner. But in the context of this patient and the most common uncomplicated UTIs, this is what we'd be looking for to move forward. And then we'll be looking for some of the other complicating factors. So this helps us to rule out whether we can carry on. So we're looking for red flags. If there's a fever present, if there's, again, flank or back pain, nausea, vomiting, those would be things where we would have to refer. Male patients, so there's no such thing as an uncomplicated urinary tract infection in males. So that's an easy one to refer out. And as well as pregnancy, or anybody under the age of 12 or immunocompromised, or looking at any abnormal function or structure or use of a catheter, or noted renal dysfunction. So some of these things would be patients be very well aware of. Some of these other things would be things that would become apparent by looking up their profile in a clinical viewer. So any of those complicating factors would be things where we would refer out. And if not, we would ask whether this is something that is a relapse or recurrent. A relapse is defined as whether it's a return of symptoms within 4 weeks of completing a prior course of antibiotics. A recurrent infection would be 2 or more UTIs in 6 months, or 3 or more UTIs in 12. And of course, in Ontario, I believe we're limited. I should have included this in there, but I believe we're limited to 2 minor ailment assessments for UTI within a year. If anybody wants to correct me with that information in the comments, would be welcome to. So anybody with these relapse or recurrent infections should be referred to a physician or a nurse practitioner. So we're typically looking for patients that haven't been treated that recently, I guess, in which case it would be appropriate to prescribe. And we look at the prescribing considerations. So the algorithm provides us with the following treatment options. So the primary recommended treatment is macrobid or nitrofurantoin twice a day for 5 days. And again, duration is important. These things have all been studied and well defined based on guidelines. If nitrofurantoin is inappropriate, you can look at sulfatrim twice a day for 3 days, or straight trimethoprim once a day for 3 days, or 100 milligrams twice a day for 3, or fosfomycin 3 grams orally 1 time, which is, in the course of much discussion with other clinicians, still tends to be preferred, just from a patient adherence perspective. So once we've established and worked with the patient to identify which one of those options is most appropriate, or looked at, resistance in our specific areas, we're going to complete the documentation. We're going to notify the doctor or primary care professional. Of course, we're going to assess the patient for improvement and side effects. So typically in these cases, we'll do that maybe in 72 hours. So we'll do a follow-up call in 3 days. If there is no improvement, if there's no improvement or things worsen, then definitely that patient should be referred. And on top of that, with all the consultation and the counseling on the medication, we can discuss prevention strategies to minimize chances of recurrence. And there's a lot of education that could go in there, whether that's, talking about condom use and urinating after sex, or we could include, recommendations, evidence-based recommendations, like including a cranberry supplement for prevention. You'll see some of the other prescribing considerations here, which we won't dive into here, but one thing of note in most of the guidance is that a culture is not necessary. Most often, E. coli is the infecting organism. Rates of resistance are fairly low. You can see them there. It's about 3% for nitrofurantoin and shows to be about 20% for sulfatrim. And then, again, going along the prescribing considerations, there has been a study that compared fosfomycin to nitrofurantoin and did find it to be inferior, thus why most of the recommendations tend to point us towards nitrofurantoin instead of fosfomycin. Looking at children, we have to consider whether they require weight-based dosing, and remember that fosfomycin is not indicated in anyone that's under 18. Of course, it's important to look at allergies and tolerances and other antibiotics that have been used, previous culture results if they have them. So again, these would be things that could be available in your clinical viewer. And also important to remember the risk of drug interactions. So, elderly patients that may be on an ACE inhibitor or an ARB that may raise their potassium levels, we may want to shy away from sulfatrim. Looking at other, again, talking about durations of therapy, not recommended. So they've fairly well established that shorter courses are just as efficacious with less risk of side effects and antibiotic resistance. And of course, we don't want anybody to end up with C. difficile. So I won't go into a whole host of detail here. So I think the summary of the slide is urinary tract infections are very, very, very common and much more common in women, which is why when we're looking at defining an uncomplicated urinary tract infection, we're typically we're talking about this occurring in women. And as you see on the side here, the majority is due to E. coli. Of course, the symptoms. So just as a quick review, most commonly we're looking at burning with urination or the need to pee without being able to pass much, increased urgency, blood in the urine, cloudy urine, strong smelling urine. These are all symptoms that are possible. And as mentioned earlier, some of the causes or complicating factors, catheter use, sexual activity, constipation can play a role, uncontrolled diabetes, holding it all day because you can't find a washroom or you don't want to go to a dirty washroom, dehydration, birth control, feminine products, and kidney stones are all potential causes of UTIs. Overwhelmingly, one of the things that I think it's a great for us pharmacists is that this is something that occupies a ton of physician visits. So over 1.64 million doctor visits per year are for UTIs. So huge savings to the hospital or to the healthcare system by enabling and providing access to this care through community pharmacies across the country. We do see that it's very common as a hospital-acquired infection as well. It's about 50% of women that do experience them, and just super common, and one of the top 3 reasons that we see antibiotics prescribed. So there's an antibiotic stewardship piece to this all as well that we want to keep in mind. And again, looking at guidelines. So as I've referenced here, we're mostly working with the Ontario College of Pharmacists algorithm that was created. A lot of that input is provided based on these guidelines from the American Urological Association, the Canadian Urological Association, and the good old orange book, the Anti-Infective Guidelines for Community-Acquired Infections. Some of these guidance you'll see are very consistent with what we've seen or what I've showed prior. When you're looking at antibiotic treatment, first-line therapies are listed here: nitrofurantoin, sulfatrim, fosfomycin, all depending on local resistant rates or what else is happening. Use a short duration as possible. And again, that's referenced in some of the guidance that we have And then finally looking at, and this is beyond the scope of pharmacy, but where there is, resistance, there may be a need for injectable antibiotics if needed. So that would be something that would be a consideration for our colleagues that we refer to. And then as well, you can, this would be something for the physician group as well, but looking at the idea of whether using antibiotics for prevention, but we can play a role with providing prevention in other ways. Certainly just one of the things to keep in mind as well is the side effects of antibiotics and how we can help our patients manage them. Of course, there's allergies, sulfa allergy. I think we all know that we have a ton of patients that think they're allergic to sulfa, and we play a role in making sure that we identify whether that is indeed the case and whether they are eligible or ineligible for treatment. Fungal infections, nausea and vomiting, GI side effects are quite common. We can also see, liver function tests, again, resistance and damaging good bacteria. So maintaining a healthy flora. So anytime we kill off bad bacteria within our systems, we do get rid of some of the good stuff that keeps our bodies functioning optimally, even if my mouth isn't functioning optimally right now. And of course, looking at non-antibiotic ways of offering prevention. So the guidance will show that cranberry prophylaxis can be recommended. And, that's something to be looked at. Again, Utiva is one of the products available, and we're looking at PAX or proanthocyanidins, which are present in cranberries. And these are the molecules that are purported to really support prevention by preventing the adhesion of the bacteria to the lining of the urinary tract. So we'll go through the differences of some of the products a little later on here, but definitely it's within our scope to recommend that patients can use a cranberry-based product for prevention. While we're talking about cranberry, we may, cranberry juice is the one thing we often discuss, and I think I've seen this change over the course of my time. I know 2006 was mentioned when I graduated. It seems like a really long time ago, and used to see a lot of patients, wanting to buy Ocean Spray cranberry juice, for preventing UTIs or even as treatment. And I think as we've learned more about the science, we've realized that that's, for one, it's loaded with sugar, and number two, you'd have to drink a whole heck of a lot to get the amount of proanthocyanidins that are actually going to be able to help prevent UTIs. So we'll be looking for products where at least 36 milligrams of PAX are available. That's the magic number to help prevent urinary tract infections. So just a quick summary on a case-based outlook here. So these are the types of patients that I think we're all seeing on a regular basis. 53-year-old female shows up at the pharmacy and tells you that they think they have a UTI. So of course, they think they can just snap their fingers and get a prescription. So we have to explain to them that, no, we're going to have to go through an assessment process, ask them a bunch of questions and document, gather some information and sit down with them privately. As we do that, of course, we get their informed consent. We go through their medical history. They're on a thyroid medication as well as a cholesterol medication. 2 kids, no surgeries. They've had UTIs in the past, but it hasn't been for at least a couple of years, which is great. So we know it's not a recurrent or a relapse. And they suffer from seasonal allergies. They're 5'6", 145 pounds. Everything else is unremarkable. They're not pregnant, which is great. They do have a sulfa allergy documented. They had severe GI upset, and of course they had a rash with amoxicillin in the past. So we'll go through the assessment again, document their complaint, their symptoms, and they tell you that it hurts to pee. It feels like they have to go all the time. The urine's cloudy. It's worse today than it was last night. They don't have any significant flank or back pain. There's no fever nor any visible blood in the urine. So these are all good things for us. It's been almost a full day. So we determine at this point that this is acute cystitis or a urinary tract infection. And we go through with them their treatment options. So we went through the treatment options with before. We looked at, obviously, Macrobid is the preferred treatment. Other options were sulfa, which we already had an allergy documented. Another alternative would be fosfomycin, but in the course of this patient, we'll just choose the Macrobid BID for 5 days, 10 capsules. We review non-pharmacological measures, so we recommend that they increase their fluids, and we explain to them they can consider cranberry with the high amount of PAX for prevention of recurrent UTIs. And of course, we go through all the counseling notes. One of note is to take with food. And as we highlighted earlier, the pharmacist is going to call in 3 days to see how they're doing. Hopefully, they're feeling much better. Okay. And then, of course, through the course of our documentation, we are going to send all that information off, keep it in our file, and do all the necessary billing elements here. So that's sort of the course of the whole minor ailment process in very short order. I'm bumping right up against the allocated time here. For those of you that just wanted to highlight the Utiva products here. So of course, on the left, there's the cranberry with the 36 milligrams of PAX in there. There's other products that are complementary as well, D-mannose and a probiotic, and they do have test strips, which are can play a potential role, but certainly not necessary. So all things there. When we talk about how hard it is to get 36 milligrams of PAX into one capsule, if you consider some of the more run-of-the-mill cranberry supplements, you would need about 9 of those in order to get the same amount of PAXs to fit into one Utiva capsule. So just something to keep in mind when we're looking at the quality of the products that we're recommending. So that's my piece here. I'm going to pass it off. I know I saw some hands go up through the course of that, and I'm sure we'll get a chance to revisit. I know Dr. Firmly will present a physician's perspective. We had a meeting, a couple of meetings leading up to this, and had some good discussions and providing the background of what the training and the tools and resources that are provided to all of us. And I think this gives us an idea of some of the considerations that our physician colleagues will be thinking of and wondering about as they receive our assessment recommendations, clogging up their fax machines.
Thank you so much, Sean, for that great presentation. We had a ton of questions come through, so I'm looking forward to the Q&A afterwards. I'm just going to do a quick introduction on Dr. Firmly. So Dr. Suleiman Firmly practices primary care at an urgent care clinic in Toronto, townclinic.ca, and he obtained his medical education and residency in family medicine at the University of Toronto. Dr. Firmly practices as a travel medicine physician, both virtually and on-site in Ajax, Ontario. He enjoys entrepreneurship and innovation in healthcare and is the Chief Medical Officer for careclinic.io, a personal health record and engagement app designed to help patients keep on top of their health. Dr. Firmly is an avid proponent of continuing education and continues to mentor and coach future trainees to reach their full potential. Welcome, Dr. Firmly. We're so happy to have you here tonight.
Thank you so much, Jody. And it's a pleasure to be here with everybody this evening. Don't want to take too long, and I don't have really a lot more to add. I think Sean did a great job of going over everything. I also went to U of T for school, as I heard Sean went to Leslie Dan. And one of the things they really ingrained in us is working in interdisciplinary teams and working with our allied health professionals. So, I think this is probably the biggest allied health endeavor I've done maybe since I've graduated. And it's a pleasure to be able to add something to the conversation, because I personally have learned a lot from all of my pharmacist colleagues over the years about all the intricacies about prescribing and medications and what's covered and not covered. So it's nice to be able to hopefully add something of value as well to everyone participating today. I think most of the topics were covered. I've noticed there were some questions here about prescribing and antibiotics. So what I could try to do is combine my presentation with also answering some of the questions together. So if we can just go to the next slide, or maybe I have control. Let me double check, or maybe Shani, you still have control maybe.
Oh, I do. So I'll advance for you. My apologies.
Thank you
Yeah.
so much. Yeah, I only have 3 slides, so hopefully it won't bother you too much. So this was already mentioned. The only reason I had it here is because one thing that really helps is being able to really hear some of those buzzwords from the patient, or being able to, or sometimes the patients themselves might not be able to better explain how their symptoms feel. And sometimes I'll just run them off the top, like from my finger quickly, and ask them very quickly, do you have to pee every 5 to 10 minutes, 20 minutes? Do you have pain with it? Do you feel like you need to rush to the toilet, or you're going to wet yourself? So being able to translate some of these medical terms into common language that most patients will use I find is really helpful. So that's why I put this slide, just kind of putting a few different ways that patients have described their symptoms to me. And sometimes if they can't describe it, at least I can list it off as well. And I find that helps a lot with the diagnosis, because there's not much else that will cause all of these symptoms in a patient. So that's pretty much it for so pertinent positives are all the things that make you more likely to think that it's a UTI compared to something else. And then pertinent negatives is just to ask for these things, so you know that it might not be something else. So you want to, in most cases, they shouldn't have any vaginal discharge, they shouldn't have any vulvar or vaginal itching. In most cases, they shouldn't have fever, or it shouldn't be just at nighttime, or not constant. Usually, if they're having these symptoms, it should be constant. And in most cases, it shouldn't be going on for longer than a week, because if it's, again, back to the acuity, which was mentioned before. We can go to the next slide. So I noticed this question was asked in terms of testing, and how helpful testing might be. According to the literature, they've actually done some interesting studies about this, and they've actually found that the one factor that has the highest what's it called, positive predictive value that they have a UTI, is actually them coming to you and saying they think they have a UTI, believe it or not. So I actually have a study of this. But regardless of that, when might it be helpful to test, and what kind of testing to do? So in addition to taking a good history, the two common tests that can be done is a quick chemical analysis, or a DIP. So we do these commonly if needed in doctors' offices. And I only try doing them, again, if I really need it and if I'm really not sure. Whereas some doctors' clinics might just do it no matter what, just if they have those symptoms. And so these are also in the test strips that you can also purchase commercially. It's, in a sense, it's kind of like a pregnancy test. A lot of times if a patient comes to you, they're like, I miss periods, I'm trying to get pregnant. I'm feeling some bloating, some breast tenderness, some nausea, all of these things. So most of the times, even as a physician, I might not even do the urine test to confirm. I will probably just go straight and order all the testing for blood. And similarly, in a pharmacy, they can also do a urine pregnancy test easily if they want to know. So again, it's optional, but it can be helpful, especially for these 3 factors. So there's leukocytes, nitrates, and blood. And if all 3 of these are positive, which usually you'll see in a UTI, or if at least 2 of them are positive, it can definitely be helpful in cases where it might be a little bit ambiguous, to give you a quick answer right away. So if you guys have bathrooms or washrooms that are accessible in your pharmacy and you're not really sure, you can just, and if you guys carry the test strips, I'm not sure if you guys can bill for them, probably, maybe not, but otherwise you can maybe offer to the patient if they want to know for sure, they can purchase the ones that are available. Utiva has their own line, and there's probably other options as well. So that might be a quick way to, or an option that might be helpful in certain situations. And then the second type of testing is the urine culture and sensitivity. In most cases, I don't have to do this. Maybe only maybe 1 out of every 10 or every 20 patients who come in with UTI symptoms do I actually do a urine culture and sensitivity. And there's a few reasons for it. Number one, it takes some time, right? It takes about 5-6 days to get it back. And really, if someone truly has a rip-roaring UTI, the last thing you want to do is just leave them to suffer for 4 or 5 days to get the results. And in fact, sometimes it's interesting, because even though you are quite confident that they have a UTI, the patients themselves sometimes might expect and say, well, we should only treat it if the urine culture is positive, or if the testing is positive. And there's a lot of emphasis placed on testing. And this could be just because of traditional values or what people are used to. However, like I mentioned, all the common evidence indicates that the highest predictive value is them just coming with these symptoms. So just on a clinical basis, a lot of the times it's quite substantial to diagnose it. Now, when are the times that I might do a urine culture? Number one is if somebody is coming back, as Sean mentioned, with a relapse, and you might want to question maybe the antibiotic I gave them, they're resistant to it. And so then is a good time to do the culture and sensitivity, because that will actually grow the bacteria and give you the list of sensitivities. And in fact, sometimes when I do order the culture and sensitivities, I'll write in there that, I prescribed this person macrobid, and it seems like it's not working. So please, make sure they include that and other antibiotics to give better options for the patient. So that might be one time, like the most common time when I might send them for culture and sensitivity. And the other thing to look out for are what are some other things that might mimic a UTI. Again, just to kind of have a broad differential diagnosis. So these are some of the common things that I commonly experience in the walk-in clinic setting. One would be overactive bladder. So this would be cases where someone is just having frequency, but not necessarily all the other symptoms. And it's usually a bit more chronic than a UTI. And that's because the bladder, the nerves that are feeding the bladder are just firing at a higher rate than usual, and they just feel that urgency and frequency, but not necessarily everything else. The second one is interstitial cystitis, and this is quite a tough one because I find that a lot of times people with interstitial cystitis, even though it's not bacterial in origin, they will actually get relief from taking antibiotics. And I'm pretty sure it's because of the anti-inflammatory effects of the antibiotics. So similar reason why people with cough and cold also jump to take Z-Pak or amoxicillin, and they feel better and they swear by it, even though it's most likely viral. So I believe it's the same situation. So this is why a lot of people with interstitial cystitis might come and they've been taking rounds and rounds of antibiotics. They swear they feel better, but it comes back. And it's also a very difficult illness to treat as well. So this is something to be aware of. And it's difficult to treat because it's kind of similar to irritable bowel or fibromyalgia. So they do have inflammation in the urinary tract. However, it's not bacterial in origin. And sometimes they might need to be seen by a urologist, do a cystoscopy, and they can actually visually see the inflammation in the ureter. The third one is obviously gonorrhea, chlamydia, mycoplasma genitalis. So any sort of UTI, any of these STIs could mimic UTIs. However, they usually might have a discharge connected with them, but not necessarily. And a lot of times these could be asymptomatic as well. So it's not bad to think about it, especially if the patient might have risk factors. And the reason why it's important not to miss this or keep this in the differential is because these can actually cause a lot of other symptoms down the road, like pelvic inflammatory disease and things like that. And there might be some other ones, but are less common, but just good to think about in case something's not matching with the history of the patient. So I think that's it. The last slide I have is about antibiotics. So this is just from my own personal experience. I know that both the algorithm and the guidelines might suggest macrobid as first line. But it could, I think it's kind of like a graph. It goes up and down, depending on the time. So if today the guideline and the macrobid has been the guideline for a long time, as far as I can remember. So if everybody's been using macrobid for 10 years, then depending on when studies might have been published to comment on the sensitivities and resistance, it might not be in real time, right? So this is just from my own, anecdotal evidence. So please don't quote me on this. And I'll just share with you guys some experience I have in terms of prescribing antibiotics and when I might use each one. So for example, fosfomycin is, I might usually use it in patients with more milder symptoms. And if they're earlier on, with their UTI symptoms. So anyone with much more milder flavor of UTI, let's say it's not recurrent, it's their first time, they have milder symptoms, it's at the beginning, and it's early, I'll just give them fosfomycin. It's very easy in terms of patient compliance. It's a one-shot deal. It's hard to find actually any drugs that work like this for most ailments. So fosfomycin is quite good that way. Then after, for more common for any UTIs that might be a bit more severe in symptoms or might have been going on for a few days, I usually use Septra because just from my own anecdotal evidence, looking at culture results, I usually find Septra actually has less resistance than Macrobid. And again, I think it's because, now that Macrobid's top on the guidelines, it's just being used a lot. But again, feel free to use your own clinical judgment or discretion on that side. And then the last one is ciprofloxacin. This is what I would also use if the patient has already tried the other three, or let's say, for example, they have resistance to sulfa and they've tried macrobin and it didn't work. So then I might go to a fluoroquinolone such as ciprofloxacin or levofloxacin as well. So these are the most common ones. There are a lot of other antibiotics that can be used as well that are less common, like for example, cephalosporins like cephalexin, which I usually don't like because you have to give it 4 times a day. If anything, I might use cefadroxil, which is twice a day, but I don't think I've really used it for UTIs. And then pregnant women and things like that, we use amoxicillin, but don't need to worry about that right now, I guess, because for pregnant women, that would fall out of scope right now, but probably maybe rolled in the future. But this is sort of my my quick and dirty approach with antibiotics that I found helps. And yeah, with I think that's pretty much it from my side. And then maybe we can jump to the question and answers.
Awesome. Thanks, Dr. Firmly. So I'll move into the Q&A. We have quite a few questions here, so let's try to get through them. So first question, how do you manage a patient who downplays her symptoms so she can get a prescription instead of spending 12 hours at the ER?
I saw this question earlier, and yeah, I think this is a tough one. I think we can only rely on our patient to tell us the truth, and I guess in this context, if you've changed the ways you've asked the questions and the answers are consistent, it's hard to argue with that. I don't know how well scripted patients are going to be with knowing the criteria and what the difference is, but I think certainly using your clinical judgment here and determining the risk. At the end of the day, it's all going to be for our own protection. It's going to be the documentation based on the information that we're provided. So I can see the challenge, because for sure there are patients that are definitely going to want a prescription and may be disappointed if we're unable to help them. But in the same breath, I think we can use all the tools in our arsenal. But if we do feel that we're unable to treat them because they may be at more risk, then we would benefit from trying to refer out. And there's nothing to say too that we can't be utilizing things like the pharmaceutical opinion program, I think, and somebody can correct me if I'm wrong here, but you could recommend a treatment to their primary care physician if it's outside of the scope of initiating your own prescription in the minor ailments process. But again, I think that's just a consideration that we could use in this circumstance.
Okay.
If I could add to this,
Sure.
if I could add to this, I just want to add two quick things. So number one, if somebody's symptoms are actually quite far gone and severe, usually they probably won't look so good just on inspection. Like, if they're with a rip roaring, like, urosepsis or something like that, I don't think it'll be possible to necessarily downplay the symptoms, because it should be quite obvious. But second of all, the second thing is that actually one of my teachers taught me that if you feel you have any patient that might be overplaying their symptoms, I don't know how helpful this would be, but he told me he had the strategy where he starts asking questions that are actually unrelated to the problem itself. And if they keep saying yes to those as well, then you know that they're probably just faking it. So for example, he will ask a question like, okay, look, when you, when you urinate, do you feel, pain behind your eyes or something like that? And if they're still saying yes, and we know that there's no correlation between that, then, maybe they're actually, over exaggerating. So we use that, I use that, I haven't used it very often, but sometimes I have to use it on patients where I think they are maybe just malingering or playing the game a little bit. And usually I found that helpful. So I don't know how helpful that is, but that's little thing I learned.
Thanks. Um, so the next question I'm going to ask Sean. So we did get a couple questions regarding postmenopausal women. So for this question, is a UTI in a postmenopausal woman considered a red flag? And does that mean a referral to an MD? I've seen conflicting information about pharmacists prescribing for UTIs in postmenopausal women.
From everything that I've seen, I don't believe it's considered to be a red flag. I believe we can still treat them. Again, there is a lot of information to parse out there, and I think we're all still learning. So I could very easily stand to be corrected here, but from the material here and considering the algorithm that we walk through, being postmenopausal wasn't a reason to rule out the ability to treat. So be looking more at the relapse and recurrence. And, again, it specifically referenced, considerate drug prescribing considerations in the elderly, which would indicate that, there is an expectation that we may be treating elderly women. So nothing that I've come across would indicate that we have to refer those patients. We should be able to treat them in the pharmacies, as best I know.
Okay.
Yeah, clinically, if I could just add quickly, the only other thing I can think about that pertaining to this question is that a lot of the changes that happen after menopause do change the vulvovaginal anatomy and the anatomy even around the bladder and things like that, for sure. And because of those changes, it might be a bit more common to get UTIs. Just the integrity of the skin and a lot of the other tissues might wane a little bit because of the hormonal changes, which can obviously affect the immune system secondarily and then lead to more UTIs. But as Sean mentioned, even from a clinical perspective, we treat it the same as anyone else. We don't really worry that they're postmenopausal. But if it's something that's recurring because of that, definitely, if there are any treatments to help with the menopause to reduce the burden of UTIs or any other underlying or secondary side effects from the menopause, then that's something that might be helpful to speak with their physician about.
So Dr. Firmly, we have a question here. I don't believe you covered this, but correct me if I'm wrong. Monourol versus nitrofurantoin in terms of efficacy and safety.
Yeah, so Monural is just another word, is the brand name, I guess, for fosfomycin. And you said compared to macrolide, right?
Yeah.
Yeah. So actually, I think I did cover that, but it was just the medicine name was different. But I normally would use Monural for someone whose symptoms are a lot milder. The symptoms just started. Then Monural is great because it's just a one-shot deal, good for compliance. Whereas Macrobid is going to be 5 days. So yeah, definitely that's how I would juggle between the two.
Okay, thank you. So the next question is, with all the concerns around overuse of antibiotics, I'd be interested in what strategies we should employ to avoid overuse. It seems to me that anyone could Google the symptoms of a UTI in order to obtain antibiotics that may or may not be required.
Yeah, it's a great question. Again, I think there are some inherent protections in, at least, again, I always speak from the Ontario perspective because that's what I know. But again, looking at the limits that are put in place for us to be able to prescribe, I think there are some protections there. I think it's a valid concern, but in the same breath, I think looking at prevention strategies as well and providing that education and making some other recommendations, including cranberry as an option, maybe ways of reducing antibiotic overuse. So these are things that we have at our disposal that we can recommend. But I think it's always potential that people are going to want to get to them. But in Ontario, I suppose if somebody's gone through their 2 consultations, you're going to see it in the flag and you're not going to be able to provide it any further. So there's almost a ingrained protection there from overuse. But I can appreciate the sentiment of that question for sure.
Just to add to that, I mean, that's where there's the science of medicine and then there's the art of medicine. And that's where the art of medicine really comes in, right? Because no matter how many algorithms or things like that we have, there's going to be a lot of these kind of gray areas where, that's where our clinical instinct comes in. And, I think we should always, listen to that instinct when we think that this patient might be, again, back to the previous situation where there's some hint that they might be malingering or something's not adding up. And, that instinct or that muscle develops over time. Once you see things over and over again, you start kind of noticing trends. So I think that's really where that part comes in, and you have to just use your best judgment, clinical judgment, if you suspect that somebody's malingering or just, I don't know, diverting or misusing the antibiotic.
Okay. We had a few questions come in regarding dipstick testing. So one question is, what benefit would urinary dipstick testing provide in a community pharmacy setting? Are pharmacies charging for this service? If so, how much? And then just to add on, someone asked, said, most pharmacies can order chem strips. So if you want to touch on that as well.
Yeah, I mean, I don't know of any pharmacies that are providing dipstick testing, not to say that they aren't. I would imagine if they were charging for the service, it would be, in the ballpark of $20 per service. That seems to be where a lot of what we're doing fitting in. And again, based on the overview here, I'm not sure how much utility there really is. There may be unique circumstances. From our perspective, it's not something that I'm considering offering as a regular offering in our pharmacy. We do have the UTIs test strips as an option for patients to purchase. So if they are insistent that they want to be able to test to determine if their symptoms are in fact due to infection, that is something that they can pick up. And of course, you could offer them to let them use your washroom if they wanted to do the test right then and there. But that would be my short answer to that question. I don't know. I'd have to defer to the experience of others as to whether they feel that that's a valuable service. But based on all the clinical and evidence to date, it's not an overwhelming need in my opinion.
And again, just to add, clinically, from experience, it's really helpful in situations where it's not very clear cut and you're not sure if this patient might have overactive bladder or something else, because nothing in the urine test strip should light up if they just have overactive bladder or something like that. Sometimes with interstitial cystitis, they might show leukocytes, which is from the inflammation, but certainly they're nitrates. Only bacteria can produce nitrates, and blood is also unusual with interstitial cystitis. So in some ambiguous cases, it might be helpful. And again, Utiva has their urine test strips that the patient might have to purchase and maybe self-administer, but it's also great if it does take a bit of time, extra time. So I guess as pharmacists and in your practice, you have to choose whether it would make sense with your workflow and things like that.
Okay. So another question here, are there any comparative studies to show that Utiva is superior to the other cranberry supplements produced by Weber, Swiss Naturals, etc.?
Just the evidence to date would be based on the PAC content. Yoti, you might be able to speak to that better than I am, but I mean the evidence that shows efficacy is specific to that content, and what you have to determine from some of the other available supplements is whether those supplements have that level of content. So in many cases not. I can say that I don't think Utiva is the only cranberry supplement that's high in PACs. There are other options out there, but they're not routinely across the board. So there's just a handful, and Utiva is one of the first and more recognizable names out there.
Yep, that sums it up. Dr. Frum, we have a specific case question here for you. So let me see here. So there's a risk of resistance for macrobid. The risk of resistance for macrobid appears to be less than 1%. It also does not appear to be present on biograms available through the downtown core hospitals. Would it not be appropriate to continue with macrobid for majority of uncomplicated UTIs?
Yeah, like as I mentioned, I think that it really depends on how real time the data might be. If those drug charts and the research shows that that's the current like as of today or within the last year or so, then I definitely think it's and it's the first line anyway of the algorithm. So definitely there's nothing wrong at all from using Macrobid. But like, you know, that saying where if your barber starts telling you about like Bitcoin, then, you know, you've already missed the boat. So, like for example, I don't know what any pill looks like, but I can tell you, I know that Macrobid is black and yellow. And I can tell you that why, because a lot of my patients will come and tell me that I had a UTI and I was given the black and yellow pill. So if all my UTI patients are coming and telling me they're using the black and yellow pill, and also, like I said, anecdotally, when I do send cultures, I do see the resistance. And I'm just telling you from what I've seen, like let's say from out of every 10 urine cultures, if I see 3, 4 of them are resistant to Macrobid, and none of them or very few of them were resistant to Septra, like in the last few months, then just the way my brain works, I'll just say, okay, you know what, maybe I should switch from Macrobid to Septra for now. And then later on, maybe the opposite might happen. Maybe Septra, I'll start seeing Septra more on the charts. And I'll say, okay, you know what, let me switch to a different one. So again, this is part of the art of medicine, right? Like, you know, sometimes guidelines, as you know, guidelines, they do take some time to form, right? There's a council, they meet, they make a decision, and that might be 2, 3 years behind what's actually happening right now. So that's just kind of how I practice. However, you know, I think it's to everyone's discretion, and you know, Macrobid is number one. So definitely don't take me wrong at all. It's totally fine to use that as first.
Okay, great. I had one question here. One second, it just disappeared. It was regarding, give me one moment. It's a good one. Okay, here. So I guess, Sean, you can answer this one. So regarding Utiva, do we still recommend it? And by Utiva, I mean the cranberry packs. Do we still recommend it if we generate an antibiotic prescription? And for how long is the patient advised to use it?
You certainly can. I don't believe there's any limitation on it unless we identify some strange contraindication. But from a prevention perspective, I would recommend they continue with it as long as they're willing to take it, right? So, you know, at least a full course. I think it depends on recurrence patterns, but I think this is one of the unique positions that we're now being put in as clinicians, that, you know, certainly worthwhile to be able to generate a prescription, but we can, you know, support some of our other objectives, as we've already identified, reducing resistance, but also preventing infection. And you know, people could stay on Utiva on a regular basis to prevent UTIs, and hopefully then they're not coming back in for another prescription within the year, and that'll do the job for them. But I fairly safe to say you could put them on it indefinitely. Maybe you want to reassess it every year or something along those lines, but that would be my quick answer to that one. Good question.
Thanks. I'm gonna do two more questions, and then we can call it a night. So the next question is, what if the patient is not sure of the timing of her last UTI symptoms? Can I still prescribe an antibiotic or refer her to her family doctor?
I think if they're unsure of the timing, then chances are it's been a while. That would usually be sort of the barometer that I would go. So I think from, you know, you can try to do some other fact checking if you have access to a clinical viewer, or checking in your own records. But generally speaking, we're looking for is more frequent. So if the timing is, if they're unsure of, I would tend to lean towards going for the prescription, unless we know that they've been treated more recently. But as long as it's going back to those algorithms and not outside that relapse and recurrence rates, then I think we'd be safe to treat.
Okay. And final question, perhaps Dr. Firmley can answer this one. What is the best treatment option for pregnant patients?
So for pregnant patients, we usually default to like amoxicillin, and then if they're allergic, we use cephalosporins. That's usually the typical, but there is evidence also for fosfomycin, and there is a few other ones as well that work as well. But it's always tricky in pregnant women because, as you guys know, they don't do trials, safety trials on pregnant women for ethical reasons. And so we use a lot of animal data for safety. But yeah, usually the default is amoxicillin or cephalosporin.
Okay, great. So with that, I'm going to end the Q&A. We got tons of questions. If anybody has any questions that are really pertinent and they do want the answer, just feel free to email me, and I'll do my best to get that answer for you. And so before we move on to the raffle, Dr. Firmley, Sean, it's up to you whether you want to hang on or not. But I wanted to thank you both for putting together a great, fantastic presentation. The timing is it's really important with the new legislation, and just kind of getting this information out there we feel is very important. So thank you for all your time and your effort.
Thanks for having us. It was great. Enjoyed it.
Thank you.